Good evening, everyone, and thank you for taking out the time for this very, very interesting webinar, which is on insulin at 100 years. So 100 years is a long time, and insulin has been saving lives since then. And today, I want to introduce Dr. Thanks, who is our main presenter today, and he heads the Dr. Gold Healthcare chain, and currently he has 4 clinics where I think, Dr. Thang, more than 500 patients you have helped to reverse diabetes?
At least 1,000.
At least 10,000. Wow. So I think everybody, we can clap for Dr. Thang on this remarkable feat. Perfect. So we also have Dr. Anish Musa with us from Ahmedabad. He is a specialist in thyroid disorders, autoimmune conditions, and runs a virtual clinic for more than 6 years now. Welcome, Dr. Musa.
Thank you very much, and namaskaram to everyone.
Thank you, Dr. Musa. And we have Dr. Ashwani, the most vibrant person in functional medicine, creating a difference, which is the need of the hour today. He practices from Bangalore, and his special program is on autism. So he works very, very closely with autistic kids, and of course with autoimmune conditions, diabetics, and other lifestyle disorders. Welcome, Dr. Ashwani.
Thank you, Dr. Preeti. Thank you so much.
Welcome. So now, Dr. Thang, the floor is yours. Please share your screen and help us know more about insulin and how insulin can change our practices for the better.
Thank you, friends, for your kind introduction. This year, we are celebrating the centennial year of the discovery of insulin. Just look at the scene. A room of death and gloom become a place of joy and hope. Just 2 scientists in the year 1922, in the month of Jan, walked in the ward of diabetic children, the type 1, who are in diabetic ketoacidosis. And literally they are helpless, because in those days before the discovery of insulin, it is literally a death sentence. So what these scientists did was that kept on injecting the pancreatic extract in each of these children. When they started finishing the last child, the first child began to wake up. And as the time progresses, in short while, all the children just woke up from their diabetic coma. You just imagine such a scenario. It's a medicine's most incredible moment. So we need to give our credits for our scientists, our Banting and Best, along with McLeod. Soon after that, they were awarded the Nobel Prize for their discovery. After this, a long decades of innovations were made in the insulin. That is, we moved on from the animal model, that is porcine and bovine, towards the recombinant technology. And also in the insulin delivery, we are now using even the insulin pen, which is not very separate from the modern pen we are using nowadays. And so comes the continuous glucose monitoring, which is very much important in type 1 diabetic patients as well, and also for the research purposes. So why are we so much worried about diabetes? It is not the sugar level itself. Mainly, what we fear is the complications, because the onset of complications occur before the diagnosis of diabetes is made. Let it be macrovascular or microvascular complications, that actually before the diagnosis, maybe 5 to 10 years before the diagnosis of diabetes is made, the complications sets in. It's a paradox, I would say. And the diagnosis, what we are making with blood glucose, is very too late, that I would say. And we will discuss in detail in the further slides. Can drugs or insulin prevent complications? Never. They can delay the complications, but never prevent them. So it is a situation of learned helplessness. Once diagnosed with the diabetes, it's actually a life sentence for them. So all the chronic diseases which I have mentioned in the screen, the common denominator is chronic hyperinsulinemia. Also for diabetes. This is the spectrum of disorders which can occur due to chronic hyperinsulinemia, which is nothing but insulin resistance, which is always called metabolic syndrome. Right from eyes to toes, let it be AMD, age-related macular degeneration. And I have seen many patients who have been cured in a week or two after suffering for too many years with vertigo, tinnitus. And let it be Alzheimer's. It is otherwise called type 3 diabetes, and stroke, migraine, and coming on to the heart and blood vessels. It is a main cause for the hypertension, cardiovascular diseases, including myocardial infarction, as well as the peripheral vascular diseases. It's a main cause for the fatty liver disease, chronic kidney disease, and gout. It is also the most important cause of infertility in both males and female, causing erectile dysfunction and PCOS respectively. Interestingly, it is also linked with osteoarthritis, and in 30% of the cases, cancers is related to diet. So what do you think now is insulin is a bad guy? No, we can't sustain life without insulin. We have to remember that. It has an evolutionary purpose. The insulin resistance is actually not bad. It is a physiological phenomenon. The insulin is, everyone knows, is an anabolic steroid. It stores magnesium. And all we know is diabetes is a magnesium wasting disease, and it enhances the magnesium deficiency, also causes the insulin resistance. And insulin causes retention of sodium. This is being implicated in the etiology of hypertension because it increases the blood volume, and it mediates blood lipids by increasing the lipoprotein lipase at the level of the fat cells. And one another pathway is included apart from regulating blood sugar levels, that is the cellular proliferation and growth, which is by MAPK kinase pathway, that is the mitogenic activated kinase pathway. So the variability in lifespan is actually regulated by insulin, and the key to longevity is you have to maintain a low insulin levels with high insulin sensitivity. So what is health? The health is nothing but we have to be metabolically flexible in between anabolism and catabolism. Whenever we eat, insulin just rises, and there occurs carb burning, and the role of insulin is energy storage, let it be carbs or fat. And when we fast and periods of not eating, the insulin levels usually falls, and there occurs fat burning. When these occurs in tandem, then you're perfectly healthy. But what we have done in the last 50 years is a matter of question. Just look at the graph above. You could see a well-balanced fat burning and carb burning, increased insulin and decreased insulin, anabolism and catabolism. But what we have done is we have changed the eating pattern, and we have defined everything, right? And we have also included the snacking. So there is an increased and frequent spikes, which is very large compared to the graph above. And there is decreased fat burning, and this leads on to the vicious cycle of insulin resistance and obesity. So the insulin gets stuck at a higher level because you are eating muffins every 2 hours to stay alive. The body gets stuck in fat burning, so the fat deposition occurs, and it leads on to obesity. At least in the initial phase of type 2 diabetes, there occurs hyperinsulinemia. What we have been taught in conventional medicine is it is due to insulin resistance. But what causes insulin resistance? It's again a $1 million question. So when you look at this picture, there are two things, the horse and the cart. Whenever we feed, we are fed with refined carbs and then refined oils and sugars, there occurs hyperinsulinemia. When it is above the physiological limits, there is a phenomenon that occurs which is called resistance, which occurs in almost every cells. They resist when there is a super physiological stimulation. So occurs the downregulation of the insulin receptors and the receptor function, which lead on to the insulin resistance. So the horse is, the hyperinsulinemia is the horse and the cart is the insulin resistance. And this is a vicious cycle. You can't separate both of them. It's the, what it says is it's two sides of the same coin. So when we look at the natural history of type 2 diabetes, in the initial period, there is no change in glucose. The glucose stays within the normal limit, maybe for a decade earlier, before the diagnosis of diabetes is made by measuring the blood glucose levels. But when you carefully look at the graph below, there is insulin resistance, which is also accompanied by increased beta cell function. The insulin is almost elevated to 5 to 7 times the normal limit. That is caused by the compensatory hyperinsulinemia, that is again caused by the secondary to insulin spikes, glucose spikes, which is occurring secondary to the ultra-processed food. By the time the diagnosis of diabetes is made, even the insulin level stays high. Only after a period of 5 to 10 years, the insulin starts falling down. So we can easily look at the picture and we have to make a dramatic shift. That is the paradigm. You have to move from the glucocentric model to the insulinocentric model. So it's very important. We have to protect the population. We have to keep the population healthy. And we are not here simply to treat when you are sick. So we are just missing the elephant in the room. We are just looking at the glucose levels, the insulin. We are again conducting research at the level of the stem cells, insulin pumps, everything. But where is the root cause? The root cause is the hyperinsulinemia that produces insulin resistance. And the primary cause of hyperinsulinemia is our dietary habit. So as we all know, there are two kinds of diabetes. We can broadly classify it into monogenic and polygenic. Polygenic, as we all know, type 1 and type 2. Type 1 is autoimmune, and it is absolutely necessary for these type 1 patients to take insulin lifelong. And you have to keep the dose as minimum as possible. And before starting insulin, even in children, you have to make a note. This should be the take-home message. But because I have treated many patients, I have reversed even many patients who have been diagnosed with type 2, type 1 diabetes. It's actually a misdiagnosis, right? So when there is a very good insulin reserve, it can be measured in the form of C-peptide, you have to think twice before starting insulin. We should not just simply treat any child or young adult with diabetes to be type 1. Because I have reversed a number of patients who have been misdiagnosed as type 1, but it turned to be type 2. And type 2 is very easily reversible. Within a weeks or months, it can be readily reversible. And coming on to the monogenic type, there is MODY, that is the maturity onset diabetes in the young, and neonatal diabetes. The interesting thing in these cases is that all these cases can be managed with sulfonylureas. And the insulin may not be necessary in many of the cases. And the very interesting thing about this monogenic diabetes is that can have a very normal C-peptide levels, and the antibody assay, that is the anti-insulin antibody assay, may be negative. So we have to subject every children or young adult with the antibody assay being negative and near normal C-peptide levels to do the genetic testing for MODY. So is there any indications of insulin? Of course, we have to use insulin whenever it is necessary. it should be used in type 1 lifelong. We have to use the lowest possible dose. When we are using the high dose, there occurs hyperinsulinemia. It again causes insulin resistance as in type 2, and which leads us to the dual diabetes, that is type 1 along with type 2. And it's a difficult situation to treat with. In type 2 diabetic patients, we have to use insulin only when the patient is having something like stressors, acute infection, or undergoing surgery in the post-op period, just because of inflammation, which may cause the insulin resistance, which is actually physiological. And in DKA, diabetic ketoacidosis, and hyperglycemic hyperosmolar non-ketotic coma. And there is a specific subset of patients in type 2, which may account for about 5 to 10%, I would say. In this patient, the insulin reserve is very poor, and these patients need absolutely the insulin or else insulin augmenting drugs. In my practice, I would say nearly 80% to 90% of type 2 patients can be reversed to normalcy without the use of any drugs or insulin. So when we use insulin and insulin augmenting drugs on type 2 patients, this occurs. The major cause of accident is the pedal errors. Instead of hitting on the accelerator, instead of hitting on the brake, we hit on the accelerator. This is what we do when we prescribe insulin and insulin augmenting drugs which causes perpetuation of diabesity, that is, obesity causing insulin resistance, insulin causing high blood sugars, and which in turn causes high insulin levels. When you are augmenting insulin again and again with drugs and insulin, it ultimately leads on to insulin resistance and it further worsens. Hope it brings some idea about insulin and the roots of diabetes mellitus. So the floor is now open for panel discussion.
Dr. Priti, you are muted.
Thanks, Dr. Ashwini. So thank you, Dr. Thank, for such an enlightening presentation. I have few questions, which I've been noting down while you were presenting. So, hyperinsulinemia and side effects of giving more insulin than required. Can, one of the panelists elaborate this a little more? I know Dr. Thang did mention the possibility of dual diabetes in type 1 diabetics. But anybody who could just shed some more light on this.
Sure. I can put in light on that. Thank you very much.
Right. Thank you.
So thank you very much, Dr. Thang, for a beautiful presentation about thyroid and discovery. So basically, we have to give all credit to our scientists who had discovered the insulin previously. But and as Dr. Thanks mentioned, in conventional medicine, usually we ignore the insulin level. See, everybody knows that the insulin resistance is a root cause. But ultimately, with an insulin resistance, the consequences is high insulin. And when high insulin happens, see, if you want to understand diabetes in simple terms, if I want to define diabetes in single word, then it's basically carbohydrate intolerance. Your body cannot tolerate that carbohydrate that convert to sugar. So in simple terms, it's a sugar intolerance. So if really we want to understand the sugar diabetes, then we have to, first question should be, what is sugar metabolism? When we eat sugar, what happens with the sugar? So it's very simple science is there. When we eat sugar go in the blood. From the blood, it has to enter in the cell. And we all know sugar cannot go inside directly in a cell. We require insulin. So in a layman language, insulin is a key that opens the door for sugar. And then sugar go inside. So primary problem of insulin resistance is your cells are not listening to insulin. And in that response, your pancreas is creating more insulin. And that is a basic mechanism of, diabetes. So even Dr. Thanks showed us, before actually you lose your control on sugar, you have high insulin previously. So already you are high insulin, and that high insulin is creating a problem. So if somebody having a diabetes, maybe they have beta cell failure, and we give them more insulin, we are doing the same thing. Like we are just putting an accelerator on and on. So that's why I think we have to control the insulin level in a case of diabetes, and that could make sugar control, and even possibly we can reverse the diabetes.
In simplistic,
Thank you, Dr. Musa. Dr. Ashwini, how can a patient know that he or she is taking more insulin than required? Will the patient feel any symptoms, or should the doctor take any detailed history?
Right. So before I answer this question, I want to take a little forward what Dr. Musa said. So there's a resistance of insulin. Why are we developing this resistance? Now, engine of the body is the mitochondria. Mitochondria has to process the fuel. If mitochondria is not working, no processing of fuel happening. Then that is leading to the resistance. Then mitochondria say, I cannot process it. Let me shut down the receptor, right? And same mitochondria also is in the beta cells, right? If the mitochondria failure is there, then also eventually beta cell will stop producing more insulin. Okay. If we have to solve the problem, we have to go to the cellular level. We have to improve the mitochondrial function so that we can improve the metabolism, so that this generates more ATP. People who have high insulin, they are low on energy. They are always tired. They are always fatigued, right? Having more insulin will lead to them not because their metabolism is so cramped up. People might be thinking I'm crazy sitting into dark. For deliberate reason, I'm sitting into dark because simply sitting under blue light under tube lights can damage our mitochondria, thereby making us resistant to insulin. So just to make the point, of course, there are other things which are causing the problem. So now in type 2 diabetes, there are two kind of modalities. One simple is they just simply, without checking the insulin, just simple lab testing that we can, fasting insulin or postprandial insulin testing can be done to know. The ideal level should be 4 to 6, I think, fasting.
Yeah, less than 6.
More than that, we should, before we prescribe anybody on drugs increasing insulin, we should check that. And if it is high, then metformin is the choice of drug, apart from the dietary modifications and lifestyle modifications. So I think this is the mitochondrial health we have to be in sync before we take any drug and prescriptions and all that.
So Dr. Ashwini, thanks for sharing this, because one point you said, which is very, very vital and relevant, is even today, I see a lot of type 2 diabetics coming to me and they have no clue about what is insulin. Means even there are some doctors whom I tell, you please come, share your fasting and PP insulin, and then I can, consult you. They say, I know my sugar levels. So, though we have studied, but because we have been into practice for so many years, we have forgotten the use of insulin. In fact, I see a lot of gynecs using fasting insulin in PCOS cases, but in diabetics we don't. I remember last week I had a patient and his fasting insulin was 293 and his sugar was less than, HbA1c was less than 6, and he was like, you are crazy, doc. My doctor says I am not a diabetic. I have no problems. You are not talking sense to me. Right? So I think a little more awareness on insulin levels. What is the function of insulin? How hyperinsulinemia and less insulin both are problematic. And therefore, we have to make sure we manage insulin levels within a range. Right, Dr. Thang?
Yeah. In simplistic terms, type 1 diabetes is a disease of insulin deficiency, and type 2 is a disease of insulin excess to start with.
Right. Unless mitochondrial activity goes so low, like Dr. Ashwini said, that even type 2 becomes a disease of deficiency. But that gives us a lot of time. We almost have 20-25 years in between. When we can act and correct and reverse the disease.
in clinical practice, I don't look into the insulin levels unless needed. There are some clues which is more accurate than the insulin, measuring the
ये
insulin levels.
कुलकर्णी सर को टाइम देख के
Whenever
बताओ
you see a
व्हाट्सएप पे
patient,
कौन सी क्लास
Shalini, please mute yourself.
whenever you see a patient with dark velvety skin around the neck, right? And then skin tags. It is
Yes.
certain that he is suffering from hyperinsulinemia. And it has been proven beyond limit that acanthosis nigricans and skin tags are more accurate in predicting insulin resistance and hyperinsulinemia than the insulin itself. So
Right.
it just takes some seconds to predict whether he is in hyperinsulinemia or else.
One more thing, Dr. Thang, which really clicks in the corporate world at least. You know, post lunch, lot of people you will see yawning.
Yeah.
Right? Immediately your mind should go to insulin resistance. Any one of us here, if post lunch we feel sleepy, we are not as alert as we are in the mornings, insulin resistance should come to our mind like this. And then we should rule out anything else.
Is it
Perfect. So,
glucose crash or crash in the glucose levels, or else something else is happening?
right. But first thing is, you know, you must look at IR in these cases. Of course, is there any connection between hypertension and insulin resistance?
Absolutely. The primary cause of hypertension is not the salt, but the sugar. And I have treated many cases which have been reversed within a week or two, right? They are in the malignant hypertension. I mean, above 210, 130, within a week or two, they have reversed back to normalcy, 130, 80. And previously, they have been prescribed all these pacemakers for the left atrial dilatation. Everything has been prescribed, and he's so happy that he has reversed the disease. The absolute thing we have to notice, insulin resistance or else the hyperinsulinemia doesn't cause the required arterial dilatation. There is a constriction in the level of the arteries when there is an insulin resistance, which is secondary to decreased nitric oxide production, firstly. Right? And this is causing increase in peripheral artery resistance, which increases the diastolic blood pressure, whereas systole is increased just because of the insulin, sodium retaining property of insulin. And whenever there is hyperinsulinemia, there occurs increased blood volume, secondary to increased sodium retention.
Right. So I think Dr. Musa, you can help me with this. High cholesterol and patients with statins. Does insulin resistance play any role in that situation?
See, I consider, as we have seen on one slide, that the beautiful slide, the elephant in the room. So I usually consider insulin as an elephant. So if your insulin is out of control and the elephant is out of control, that will disturb so many things. Insulin as is a sodium retention, so it creates hypertension. Also, insulin we consider is a pro-inflammatory. See, again, as I mentioned it's a carbohydrate intolerance, means your cell cannot digest sugar. So now your insulin is out of balance, and high insulin, that insulin convert your sugar into triglycerides. And that is the first thing we see in each and every patient. So I would like to share one story of my earlier patient. So I think 1 week back, I got a patient who is a dentist and very young dentist, 31-year-old. So he is obese and he gone to his regular physician, and he found his triglyceride level is very high. So what they did, they started statin drug, even without calculating the risk of developing heart disease. So basically it's a insulin resistance. When the insulin is high, insulin convert your sugar into triglyceride, and that's why you may be having a fatty liver. And when you take a detailed history of that patient, usually you find out 5 years, 6 years back they had find out the fatty liver. So an increased insulin or hyperinsulinemia, that is creating, and that is a problem with an high cholesterol and this thing.
Thank you, Dr. Musa. And you know what? I generally tell my patients, insulin loves fat. If you are high on insulin, your body is going to store fat. And we all know that is going to reflect in your cholesterol levels.
Exactly.
Right? So thank you for explaining it. Dr. Ashwini, gut infections, do they have any role to play in insulin resistance?
Oh yes, thank you so much for this. It's a very good question. So we have few type 1 diabetics in the RAP programs. Most of the time we see they have a fungal infection or dysbiosis. And today also I think there's some research, it's not so much prevalent not to the people, but it says that infections can cause down regulation of the insulin receptors. The receptors will be killed down if there are too many infections in the gut. So yes, this infections which are not largely looked into, in the clinical practice, gut infection, they are chronic level infections. Nobody bothers about them. Nobody tests them. Nobody's, do anything about it. And they are the source of a lot of toxins over a period of time. And they also does a lot of damage to the mitochondria. Now, just the last question that you asked about the hypertension and the statins. Now, statin is a drug which is poison to the mitochondria. So there's enough data saying that anybody who on a statin within, I think, 4 years, 40% of the people will develop diabetes.
Exactly, which is so unfortunate.
Yes, their mitochondria, their CQ10 processing is hampered, and their mitochondrial function is hampered, and they become poor on glucose metabolism, and they develop diabetes. So I think, and the good thing is today we can test all these things, right? We can know what is not right and what is right, and we can fix that rather than just doing a blanket bombarding.
So, Dr. Ashwini, on this, I have a question from Amit Sarkar. Thanks, Amit, for asking your question here. And Dr. Ashwini can only answer because he's just closed at that. What are the tests to differentiate between type 1 and type 2 diabetes? So that, Amit can differentiate between the two.
I think the simplest one is the fasting insulin and postprandial insulin.
And C-peptide.
Peptide, yes.
To some extent. So this can help, and of course for type 1, if the patient really wants to go into detail, there are 5 antibodies which can be tested, and out of those, minimum 2 have to be positive for us to know that this is an autoimmune diabetes case, which is type 1 diabetes. Amit, I hope it answers your question. So there's another question from Dr. Varsha. So Dr. Varsha is asking Dr. Thang's number for consultation. So Dr. Thang, I will post your number here. Or maybe Dr. Thang, please post your number in the chat box.
Sure.
Yeah. And the question Dr. Varsha has is, can a comprehensive diet chart be provided for diabetics and those on insulin dependent? Dr. Thang, this is for you only. Usually everyone says only things what to avoid, but seldom gives substitutes and the things to actually eat.
So for type 1 diabetic patients, what we have to look into is we have to keep the insulin level at the lowest possible state. So the insulin should be at the lowest possible level, and there should be higher insulin sensitivity. So you can give low carb or else the high carb, not the combination of two, right? Which is being often advised in a standard diet.
So, Doctor,
he can go for whole food plant-based diet, or else even the low carb helps, but it should not be combined carbs and fat at the same time, which causes insulin resistance according to the Randall cycle.
Right. So, Dr. Thang, I would request you for everyone's benefit, if you can, means only if you can, post a sample diet plan.
Yeah.
So that people can get, but thanks for bringing this point up, because I see a lot of diet plans where this mistake is happening. They are adding fat, but they are not decreasing carbs. Now that actually spoils the situation rather than helping the client. If you add fat, you have to make sure that you decrease the carbs, if not by 1/3, at least to half than what the patient has already been eating.
As opposed to type 2 diabetic patients, the type 1 diabetic patient can enjoy a better things, right? Only thing we should see to that he doesn't develop insulin resistance.
Right. Perfect. So yes, Siddharth wants to know, and who is going to answer this? Can the mechanism behind yawning after lunch be explained?
I think yawning I wouldn't say, but the simpler could be the energy production. The cells are not metabolizing properly. The mitochondria is not using the energy, using the food to make the ATP. This is possibly one of the reasons.
Yes, and what happens then is the body feels stressed out, lethargic, low on energy, and that's when, generally you yawn, you want to rest, because the body is now overwhelmed with the insulin resistance and the heavy lunch people have had.
Yes.
Right? So, thanks, Dr. Varsha. I'm sure Dr. Thang will post a diet plan which will be helpful for all of you. So, Shalini says, so for type 2 diabetics, carb intolerance is there and indirectly kind of fat intolerance. So, what could be the preferred proportion of macro distribution? Shalini, not fat intolerance, but I will definitely want the panelists to answer this. Yeah, Dr. Varsha, Dr. Thang will share his number also. I've already told him, requested him to do that. Yes, about carb intolerance, fat intolerance.
Yeah. We have been thinking that there is carb intolerance. I will not accept it fully, because at the later stage that occurs carb intolerance. Before that, there is a lipotoxicity that occurs to each and every cell. Firstly, at the level of the adipose tissue, and next at the level of ectopic tissues like liver, pancreas, and visceral tract.
Sorry.
So I have been treating patients with type 2 diabetes even with very high carbohydrate diet, but I see to that it is not refined. You can have the benefit of low carb with even high carbohydrate diet, but it should be slow carb. It should be the traditional diet.
Complex carbs basically, so that they release sugar slowly and gradually over a period of time.
Yes, what the West has misunderstood about carbs is whenever we say carbs, they just think it causes spike in insulin. It doesn't happen so with our traditional grains.
Right. It doesn't happen with any complex carbs.
Yes, of course.
Basically,
they
when we talk
any
about
complex carbs in the form of actually legumes, pulses, lentils. More importantly, the traditional grains. It should not be refined or polished. That's the key here.
Right. And Shalini, when I say insulin loves fat, it means insulin is a fat storing hormone. If there is hyperinsulinemia, that will result in storage of fat. So cholesterol levels will go haywire. Fat intolerance is not seen, but yes, when high carbs are there and we add fat, our body is used to metabolizing carbs first. So our body metabolizes carbs and fat is not used generally, so it gets stored. And that is the reason if we increase fat in the diet, we have to decrease carbs so that our body starts to metabolize fat.
Yeah, kind of.
Yeah.
Right?
Okay.
Yeah, hope this helps. And yes, we will be posting the recording of this session on the IFM Facebook page, right, Dr. Ashwini?
That's right.
Perfect. And if you have any questions, you can always reach out to us on that link and we will be happy to answer. Dr. Thang has already shared his number. Anyone who has any further questions with Dr. Thang, please reach out to him directly, message him, and then you can connect with him. And thank you, Dr. Thang, for such an interesting topic.
Yeah, thank you.
Such a nice presentation. And thank you, panelists, for very, very enlightening answers. I'm sure all of us have gained something today which we were missing in our practice. Thank you, all the best, and let's make India diabetes free.
Thank you so much, Dr. Preeti, for your time.
Thank you, and have a great evening.
And I'm requesting everybody that who had not registered for conference on 19th December. So please share this message to everybody that we are running an entire day conference. So please join, and also share our link to whoever interested in learning functional medicine. So we have a different topic on that day. We are also covering metabolic health, gut health, and also we talk about the depression, anxiety, and autism. So make sure you come and that conference and learn more functional medicine.
Wow, thank you, Dr. Musa. And the highlight of the conference is what can you do on Monday morning to help your patient who is still struggling with the problem. So it is not something where you will hear hi-fi things but nothing practical. We will make sure you have a lot of Monday morning tips to go back with. So please adhere to Dr. Musa's request and do register and help your friends register and join this wave of functional medicine in reversing lifestyle disorders together with all of us. Thank you and have a wonderful evening. And thank you, panelists, again for being here. And thank you, participants, for being here. Thank you very much. Bye-bye.
Bye-bye.
Bye. Bye-bye.